It's my pleasure to introduce all of you to Dr. Dorothea Haas, who's here at the conference for the first time. Dr. Dorothea Haas has been a metabolic consultant at the Division for Child Neurology and Metabolic Medicine at Heidelberg University Hospital since 2004. She's a qualified pediatrician with an additional subspecialization in pediatric metabolic medicine. In 1999, she started a research project on defects of cholesterol biosynthesis and transport, initially as a fellow at Kennedy Krieger Hospital in Baltimore in Richard Kelly's lab. She continued her studies in Heidelberg, funded by the German Research Foundation, and habilitated or specialized in 2016 on this subject. Dr. Haas takes care of children and adults with Smith-Lemli-Opitz syndrome and other inherited metabolic diseases. She also helped to build up an outpatient clinic for adults with inborn errors of metabolism, which she now directs. She's also the head physician of the Heidelberg Metabolic Laboratory. We're so grateful that she's come all this way. Ladies and gentlemen, Dr. Dorothea Haas.
Well, thank you. First of all, I would like to thank Gretchen Noah and the organizers for inviting me to this wonderful conference. I've learned so much during the last days, and well, I'm happy to be here. Well, first, I come from Heidelberg, which is in the southeast of Germany. I think there's a pointer here. Oh yeah, that is. So Heidelberg is here, south of Frankfurt, and Berlin is here. So it's quite a small town for American use. We have 160,000 inhabitants, and Heidelberg is quite an old town, and it's famous for its castle, which you see up here on the hill. Well, unfortunately, it was destroyed by French troops in the 17th century, so it's just a ruin. But it still attracts many tourists who like to see the view on the Neckar River from up there. Heidelberg is also famous for its university, which has been founded in 1386. And one of the first faculties was the medical faculty. So this is our hospital today, our hospital for children and adolescent medicine. As it was explained before, I'm a pediatrician, and so are most metabolic physicians in Germany. So this is a problem when our patients get to adulthood, because then we are not familiar anymore with the problems that arise in adult patients. So this is why we had a association with our adult endocrinologists, and it started in 2014, and now we are really a good team, and we trained them to about metabolic disorders, which they didn't know before, and well, they helped us with other problems we didn't know. So on this picture you see our team of the metabolic outpatient clinic. Those two are from the endocrinology department. Lia Sendrödi is the head of the department, and Alborin Stiller, the pointer doesn't work anymore. Well, it's the one in blue. He's there seeing the patients, and all the others are pediatricians, as I am, and we are taking care of patients with metabolic disorders. Well, I was my first patient, Lisa, I met in 2004, in 1994, when I was a resident at Marburg University Hospital, just a small hospital. And this little girl was in our neuropediatric outpatient clinic. And she had feeding difficulties. She was a little small. She had slight developmental delay. And she had a low muscle tone in the trunk and a hypertonia in arms and legs. She had quite a small head and a peculiar face. And you see this, this feet deformity. And she had syndactyly of toes 2 and 3. Well, at that time, we didn't know what that was, but we looked at the literature and found this publication you are all familiar with, of David Smith-Lemli and John Marius Opitz from 1964, and thought that our patient looked similar. But my consultant at that time said, well, this couldn't be because she was much too mildly affected. She didn't have any internal malformations, no organ malformations. And she was just a little bit off in her development. So we were quite lucky that in 1993, 1994, as Bob Steiner explained, the biochemical basis of Smith-Lemli-Opitz syndrome was elucidated in this wonderful publication by Mira Irons and Steve Tint, and that we knew that, well, pointer doesn't work anymore, that in GCMS analysis, we should find elevated 7-dehydrocholesterol and low cholesterol. We didn't do this analysis in our lab at that time, so we sent it to London to Peter Clayton's lab, and it came back with elevated 7-dehydrocholesterol, confirming that Lisa indeed had Smith-Lemli-Opitz syndrome. So this is a simplified way of the cholesterol biosynthesis pathway. And you see that the block is at the last step of cholesterol biosynthesis. The enzyme is called 7-dehydrocholesterol reductase. And this block leads to a reduced cholesterol and an increase of 7-dehydrocholesterol and also of another sterol, 8-dehydrocholesterol. Cholesterol is the precursor for bile acids, steroid hormones, and signaling proteins, so they are low as well. Bob Steiner has already elucidated the function of cholesterol. Cholesterol is a structural element of membranes and myelin. Myelin is necessary for the insulation of nerves. You see it here. You see this neuron with the blue rings, and this is the myelin. And cholesterol is also important. It's a component of cavillar and lipid rafts, and those are necessary for intracellular transfer. And cholesterol, as I said, is a precursor of bile acids, steroid hormones, neurosteroids, and embryonic signaling proteins. But the biosynthesis pathway is not only necessary to build cholesterol, but from this pathway, you also have glycosylation, translation of proteins, and differentiation of cells, and also mitochondrial energy transfer. And mitochondria are the batteries of the cell, so it's very necessary. So it is thought that cholesterol deficiency leads to some of the developmental defects. And in this quite old paper from Richard Kelly and Raoul Hennekam from the year 2000, they looked how many patients had which kind of malformations, and they came up with brain midline defects in about 37%. And do you have another pointer for me, because this doesn't work? Well, it switches, but the pointer doesn't point. It works? No, the pointer, the green one. The laser pointer, it works? Oh, okay, so I'm sorry, I didn't press hard enough. So, okay, yeah, now it works. Yeah, you see in this is an MRI of the head of a patient, and you see here that a structure called corpus callosum is not there. And this is necessary for the connection of the two hemispheres of the brain. Then many patients in this study where 47% have cleft palate, and there may be heart malformations in about half of all patients. There may be kidney malformations, hypoplasia, that means kidney is small, ectopia, that means it's just not at the right place. There may be cysts, and also malformation of the urinary tracts, and this happens in about half of the patients. Very common in male patients are genital malformations, and you see here a condition which is called hypospadia. Some patients also have undescended testicles, and in some there may be frank female genitalia, or they are genetically male. Patients often have skeletal malformations and very, very frequent syndactyly of toes 2 and 3. But there may be also redundant fingers or toes and foot deformities, as you saw in my first patient. So Smith-Lemli-Opitz syndrome is an inherited metabolic disorder, and the inheritance is transmitted autosomal recessively. That means that you usually your genes are responsible, they are building plans for the body, and patients are affected by Smith-Lemli-Opitz syndrome only if they have 2 defective genes for 7-dehydrocholesterol reductase from both their mother and their father. That means this child has SLOS because it has both genes, and both mother and father, they are carriers of this gene, but they are healthy because it's sufficient to have 1 healthy gene. So what does that mean for other children, for siblings of the affected patient? So there may be the possibility that when the couple gets pregnant, that mother and father both give a healthy gene to the child, and then the child is healthy and is not a carrier of Smith-Lemli-Opitz syndrome. Then there's the possibility that the mother transmits the defective gene and the father the healthy gene, and then the child will be a carrier, but it will be healthy, not affected by SLOS. The same is true if the defective gene comes from the father and the healthy gene from the mother, but only if both parents transmit their defective gene to the child, and it will have Smith-Lemli-Opitz syndrome. So that means that for the next pregnancy, the risk for another affected child will be 1 in 4, but it's just statistically, so you cannot tell for sure. So something about the frequency and distribution of Smith-Lemli-Opitz syndrome. Certain studies have shown that the incidence in North America is between 1 in 20,000 to 1 in 100,000. It's more frequent in Eastern Europe, especially in the Czech Republic, and it is less frequent in East Asian and African populations. Well, and then there was this study from Lazarin in 2015, and they showed that the carrier frequency in Caucasian Americans is 1.7%, which would mean 1 in 59 persons. So this is a lot because you could find 1 carrier in every bigger bus. So you can calculate from this carrier frequency how many Smith-Lemli-Opitz patients would be expected, and it would be 1 in 13,000, which is much, much more than the incidence we have found. So, and the discrepancy was explained by these authors due to fetal loss. It seems that carriers for Smith-Lemli-Opitz syndrome have a higher possibility to lose the fetus if the fetus is affected by Smith-Lemli-Opitz syndrome. But also there's the possibility that older patients with mild Smith-Lemli-Opitz syndrome are just not recognized, not found. So you all know, and by looking at all the children here, that Smith-Lemli-Opitz syndrome has a wide variability. So on one hand, there's the severe phenotype, like this little boy, and those children may have malformations of internal organs. They usually have persistent severe difficulties of feeding. They may have a risk for severe infections, and they have a severe psychomotor and cognitive impairment. In those patients, usually behavioral problems are not very prominent. And on the other hand of the spectrum, and there's everything in between, there is, I don't like to call that mild phenotype because they also have their problems. So I like to talk of moderate phenotype, and you see this girl, which looks completely healthy, but she isn't. She also has her behavioral problems. And those patients have minimal or no organ malformations. They may have feeding difficulties if they are usually transitory. They don't have any, they are not prone to infections. Most patients are really healthy and they don't get any infections. They have mild intellectual impairment, but the big problems are the behavioral abnormalities, which may be really severe and a challenge for the families. Well, it's how could we determine severity? Well, of course, there's some genotype-phenotype correlation. So the type of DHCR variant is important, but it doesn't tell us all. Well, the type of variant determines the amount of residual enzyme activity. And of course, the more enzyme you have, the better it is. But there are other factors. And Martina Witsch-Baumgartner from Austria nicely showed that there is a positive effect of some maternal ApoE genotypes. ApoE is important for the transport and transfer of cholesterol. So there may be an increased transport to the uterus and to the fetus in pregnancy. So now I come to Smith-Lemli-Opitz treatment, and Bob Steiner has already told you something, but I just wanted to tell you how we do it in our hospital. And well, I personally aim for cholesterol supplementation in all patients. And in one of our papers, we could show that cholesterol supplementation indeed rises the serum cholesterol concentration. And these are patients with a mild phenotype, and also even more cholesterol increases in patients with a severe phenotype over time. And there have been publications that weight and growth increases on cholesterol supplementation, that there is reduced photosensitivity because children with Smith-Lemli-Opitz syndrome, they are very sensitive to sunlight concerning their skin and also their eyes, and even brief sun exposure may really lead to severe sunburns, and this gets better on cholesterol. In severely affected patients, there may be a reduced frequency of infections, and there may be an improvement of tactile defensiveness. There are some case reports reporting that it improves behavior, but well, this is not really sure. Well, as Bob Steiner said, cholesterol does not pass the blood-brain barrier, so there is no effect on intrinsic cognitive abilities. Well, how do you supplement cholesterol? Well, of course, there's egg yolks, as Bob Steiner already said, but it's my impression that it's really, really difficult for families to give egg yolks for a longer time to the children because it's just not tolerated. It may be tolerated for the first time, but not over years, because you really have to get a lot of egg yolk. So the dosage I aim for children is 100 to 200 milligram per kilogram per day. And I adjust it from measuring cholesterol concentrations. Well, in adults, I usually give a maximum of 3 to 4 grams because higher dosages are just not absorbed by the intestine. Well, one egg yolk, depending on the size of the egg, maybe 180 to 220 milligrams. And well, a good source of cholesterol is the pure powder or crystalline cholesterol. In Germany, it's not approved for clinical use, but we do it nevertheless. In Germany, there is this preparation cholesterol module from Nutricia company, which we already talked about. And it unfortunately contains a lot of sucrose, but this may be good in really small children because the sucrose adds more calories. But in older patients who don't need additional calories, it's not so good because they tend to get heavy. And this is not good for patients who have muscular hypertonia because, well, you can't carry them anymore because they're getting heavy. They are less ambulatory because they get heavy. So it's not good in older patients. And the sucrose may lead to vomiting, as we have heard. In America, there are other preparations, but I'm not familiar with them because we don't have them in Germany. And the pure powder should be dissolved in fat, butter and cream or oil, or in formula, just to ensure enteral absorption, because cholesterol is a lipid-soluble molecule, so it will not be absorbed if you just dissolve it in applesauce or something like that. When you are tube feeding, it's good to dissolve the powder in oil or cream and mix this with part of the tube feed because it may obstruct the tube if it's not properly dissolved. So, and then I would like to talk about Simvastatin. Simvastatin was developed for persons with high cholesterol. It blocks one of the first enzymes of the pathway, H&G-CoA reductase, and therefore reduces the flow in the cholesterol pathway. And it may be paradoxical to use this in patients who have low cholesterol, but Peter Jera in the year 2000, Peter is from the Netherlands, he tried it because he said, well, he wanted to decrease 7-dehydrocholesterol. Oh, I have problems again with this pointer, but here. Okay, he wanted to decrease 7-dehydrocholesterol, and therefore he applied Simvastatin to the patients. And what happened was that not only the 7-dehydrocholesterol decreased, but cholesterol increased. And later it was shown that Simvastatin can increase the expression of 7-dehydrocholesterol reductase. But this may only happen if there is sufficient residual enzyme activity. If there is no residual enzyme activity, then it may be deleterious, because in cell culture, it could be shown that the cells died when they had were cells of a patient with null mutations, because then you just block everything and you don't have anything at all. So I only give it to patients with a mild phenotype with sufficient enzyme activity to avoid those problems. Well, what does Simvastatin? It reduces efficiently 7-dehydrocholesterol, and especially the ratio of 7+8-dehydrocholesterol to cholesterol. It reduces the irritability. This was shown in this double-blind study of Basif and co-workers. As side effects, Simvastatin may lead to elevation of a muscle enzyme, CK, creatine kinase, and of liver enzymes. But, well, this is a typical side effect, which also happens in patients with hypercholesterolemia, and this is not specific for Smith-Lemli-Opitz syndrome. So you should check liver enzymes and CK when you use Simvastatin, and if you see an increase, then stop it and it will go back to normal. I saw in some of the more severely affected patients deterioration of behavior and sleep problems, but I'm not convinced that it's due to Simvastatin. In most cases, we stopped it for a time, and then we tried it again, and most patients didn't have this problem anymore. But some families didn't want to start it again because they said, well, we don't want to try it again because we believe that these behavioral deteriorations are the effect of Simvastatin. Well, there had been a recent Cochrane review in 2022, and they showed that there are just not enough studies, not enough trial to show the significant evidence of benefits of Simvastatin. And they concluded because of the risk of side effects, they would not recommend to use Simvastatin. It's not what I think. I would try it in mildly affected patients. I would explain to the families what could happen and to look out for worsening of behavior and to check transaminases and CK. And if they say something, if they see something abnormal, then stop it. And yeah. So behavior and sleep problems are a big challenge to families. So what could you do to improve that? Cholesterol supplementation may improve behavior. It's not always the case, but it may help. And well, in patients with more mild or moderate cognitive impairment, behavioral interventions may help. There are special psychiatrists who do that, or psychologists, but it's very hard. And there are not many specialized psychiatrists who would like to deal with patients with cognitive impairments. So it's difficult. Sometimes it may be necessary to use antipsychotic medication, but you have to be careful because some of the antipsychotic medication may have an increase of 7-dehydrocholesterol. Concerning sleep problems, melatonin is effective in pediatric patients. and you don't see any deterioration of steroid pattern when using melatonin. But in Germany, the insurance doesn't cover for it, only if you have an additional autism spectrum disorders, which can be easily set by most of the Smith-Lemli-Opitz patients. Well, I'm not talking about antioxidants because this is being covered in some next talks, and bile acids on. So let me see. So what we do is we issue an emergency pass to all patients concerning illness and surgery, because in surgery and in severe illness, there's a risk for adrenal insufficiency, and patients may die from that. So it may be difficult with the airway management because patients have micrognathia, that means a small chin. They may have palatal abnormalities like cleft palates, and cholesterol can only be given orally. And when you have to be in a fasting state for the surgery, it's not possible to give it. So our emergency regimen is dependent on the severity of the Smith-Lemli-Opitz phenotype and on the type of intervention. And we consider steroids around the intervention to avoid adrenal insufficiency. And if it's a surgery with a lot of tissue damage, we also consider fresh frozen plasma because this is a good source for cholesterol. Well, we know a lot, but there are many things we don't know yet. We don't know the complete range of phenotypes. We don't know the clinical course in older patients. We don't know which is the best biochemical marker, and we don't know much about the effect of medications because there are no good clinical studies, and we do not know about survival and cause of death in older patients. So in Europe, in 2017, the European Union created 24 European reference networks, ERNs, for rare diseases. And the aim is to exchange knowledge and experience across borders. And one of these networks is META-ERN. It's dedicated to inborn metabolic rare diseases, and it's led by patients and experts. And it comprises 92 healthcare providers and 41 patients' organizations from 27 European member states. And Smith-Lemli-Opitz syndrome is represented in the subnetwork for axosomal and lipid-related disorders. And we created diagnostic, clinical, and therapeutic education programs on different metabolic disorders, also on Smith-Lemli-Opitz syndrome, which has just now released, and it's for physicians, for trainees, and medical students. But we plan to do a webinar for patients and families affected by SLOS, and it's being done by doctors and by families and by our patient representatives. So we also plan to do a Smith-Lemli-Opitz natural history study. It's registry-based, and it's registry-based so that we get a lot of patients included, and that the threshold for entering the study is really low. And we do not do any additional examinations. We just take the data we have and put it into the registry. And our registry is called UIMD, Unified Registry for Inborn Metabolic Diseases. So it has some core data elements, and then there are data for every visit. And we would like to evaluate the frequency of malformations, the type of cognitive impairment, the frequency of gastrointestinal syndromes, the incidence of adrenal insufficiency. We would like to know about bone health. We are interested in psychiatric abnormalities, interested in hypersensitivity, how many patients do have frequent infections, is there neurodegeneration in older patients, and is there a risk for malignancy, for cancer? Oh, okay. In this network, we have very active patient representatives, and they help us talking to patients about this project. But they also had their own survey because we wanted to know what is important for patients. What do families want to know? What are they interested in? And Karin Mosler, Antje Enneke, who is here, and Anne Kalweit designed this survey and sent it to the different patients organization in Europe. And we got 49 answers of 49 families in 7 countries, most of them in Germany, but also in Spain, in Portugal, in Romania, in Sweden, and in the Netherlands. And well, the severity was evenly distributed across those patients. And the most important question the families had is, well, we should evaluate the difficulties with feeding and poor growth. The next important issue were behavioral issues and sleep disturbances, also hypersensitivity to auditory or visual stimuli or touching, and then less important, impaired cognitive functions, vomiting, sensitivities to sunlight, gastrointestinal issues, and orthopedic problems. The families wanted to know especially a lot of about the variability of Smith-Lemli-Opitz syndrome, about the life course, and they are also interested in the project and would like to share data. And they are very interested in an SLOS European network. Well, so far we have included 71 patients in our registry. Most are from Germany. And we are still working that other countries join us and put their data into the registry so that we learn more about Smith-Lemli-Opitz syndrome. Okay, I want to come to the end, and this is the wonderful collage which has been done by our patients representatives, shows patients from Germany and from Sweden. And I think it shows that they are all happy children, which are really great children, and and I think it's important for you to see that also, and so thank you for your attention, and I am happy for questions.
Thank you. There's one question online. Have you seen any patients with laryngeal clefts?
Which one?
Laryngeal clefts?
No, I haven't.
All right. Any other questions in the room? I see some hands up over here. I want to be mindful of time as well as we prepare to hear from Dr. Elias.
So there's a few questions actually. The first one was, you said about, because we have the nutritional cholesterol, but in the tin it says dissolve with water. And we have been struggling to dissolve the cholesterol. So we add it directly to her blends. But sometimes because it's so sugary, it becomes a block. So you said you have to dissolve it. How do you actually dissolve it with fats? Do you just mix it with oil, or?
Yeah, I think it's best to mix it with oil. Well, what kind of nutrition do you have? Do you have like
the same you show in the picture?
Yes. I think it would be best to mix it with oil. You could also mix the solution that you produced with oil with warm water, and then it may dissolve better.
Okay.
Thank you for that question. Any others, JB?
Just a quick question. I like the survey idea and surveying all those countries. Do they all speak German, English, French, or
No,
British?
actually, the patient representatives were very active, and they translated the survey to 16 different languages, so that every patient could, or every family could answer that in their own language. So this was, of course, very good because this lowers the threshold.
I'd like to say how grateful we are to have this European perspective on Smith-Lemli-Opitz syndrome, and we so appreciate the work that you all have done and that you've brought it to our attention today. So one more time, Dr. Haas.